Medicaid work requirements take effect in every expansion state by January 1st, 2027. But half the states just sued to stop the rules that govern them. They're challenging a new federal rule that narrows who counts as medically frail, and it adds paperwork for people trying to prove they're exempt. We're going to discuss what this fight means for coverage, for providers, and for the states preparing to implement. Welcome to CareTalk, America's home for incisive debate about healthcare, business, and policy. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the chairman of the UConn Health System. David, what other news do we have today? I've been spending a lot of time on Google myself.
Well, John, we both celebrated birthdays recently, and I was going to go to Google and search, what they were going to give me for a gift. And lo and behold, John, if you type in healthcare podcasts to Google, the AI comes up with the answer, and it says there's thousands of healthcare podcasts out there, but it says the top one, is CareTalk, and it says by David Williams and John Driscoll, co-hosts.
So
that was my birthday gift.
Your name got listed first again.
Well, it may have said it the other way around, but I listed it. That's how I read it. It came across as first. But, John, it's a gift.
It's congratulations to our listeners. I mean, this is all about the wonderful listeners we have, many from healthcare, from all over healthcare in the United States, coming to us to answer questions. And we got a gnarly one this morning, this Medicaid work requirements. I mean, healthcare is complicated enough, and then you get into partisan politics and 51 different systems. This is the Medicaid is to the state and federal program really run by the states, but funded at least 50% typically by the federal government to take care of the poor. And everything's sort of changing as of January 1. How did we get here, Dave?
Well, John, we got here with our birthday month last year when the One Big Beautiful Bill Act passed in July 2025. And it was saying that any of the adults that were involved in the Medicaid expansion, which expanded Medicaid under the Affordable Care Act, have to document 80 hours a month of either work, school, job training, or community service, or somehow prove they're exempt. And now we're getting into how that's actually being implemented. And of course, the states have had a year to get ready, and there's some things that are now coming along, John, that are making it a little bit harder for them, and the states are not happy.
Well, I mean, this is one of those issues that polls well. Everybody wants folks who can full-time work, who are doing nothing else, to have an incentive to work. That is something that I think most Americans agree on. And coming out of the pandemic, there was a real concern about, particularly young adults, but honestly, any able-bodied person to get, back to work. And, unemployment fell, but that remains a really high motivator for folks not to get benefits if they can qualify them for otherwise by full-time work with full benefits, or full-time work without benefits and then qualify for Medicaid, except for those who can't work. It seems quite logical to the average voter, but the systems that Medicaid uses to really identify coverage are not identical to those that could validate work or readiness to work. And I think therein lies some of the complexity here. And obviously the Republicans are for these work requirements historically, and the Democrats are against it. The Democrats tend to be more motivated by covering more people who are poor or near poor and make sure they get coverage, because if they don't get coverage, they end up getting sicker, and it burdens the entire system, because people only then get care when they're very sick. But Dave, how complicated is this for the states to set up a system to verify work?
Well, it's pretty complicated to do that, but I think they've done it to a reasonable extent. It's something that they can set up, although there's still a lot of then self-service on the part of the Medicaid recipient or would-be recipient to go through all the documentation. I mean, if you've ever been to let's say, trying to get your driver's license transferred from one state to the other, and you have to have specific forms and all that, there's a lot of times it doesn't actually work out. And so it's pretty complicated to jump through those hoops, John. And that is part of the point, which we can come back to. It's the idea that you're going to actually have the savings that the big, beautiful bill calls for. A lot of that is by people not being able to fill their forms in correctly. That's actually what comes out of it.
Well, and cynics would say that it's just simply by creating more barriers to get coverage. I mean, I believe you have to verify coverage every 4 months. If someone is working 2 or 3 low-wage jobs, it may be hard to get the time off. I know in my state of Connecticut, those offices historically have been open 9 to 5 when the average full-time worker who would qualify for Medicaid doesn't have time off or can't necessarily organize themselves to even get to that location, let alone have all the documentation they need. So I think the practical reality and historically it has been kind of hard to actually make this work in a way that didn't actually turn people who are full-time workers off of Medicaid.
So, John, I know you talk about, what a cynic would say. And one of the first things I remember from starting college in your state of Connecticut was they said, cynicism is sort of like a poor, weak substitute for skepticism. And skepticism is okay. In this case, there are consistent findings from where these sort of things have been tried at the state level, Arkansas and Georgia, that, including from the Congressional Budget Office, that the work requirements don't actually meaningfully increase employment, but they do increase disenrollment that's driven by just paperwork errors and increases medical debt and delayed care. So that is not a cynic's view. That is just what the evidence shows.
That's a really fair point. That that historically, I think in every case this has been tried, the result has not been more workers. It's just less healthcare getting to poor people. And that is, I think, pretty well validated. Now, the administration's making a good faith effort to try to standardize and simplify, leveraging technology, the tools that the states would use to verify employment and get access to Medicaid. But that's sort of the first time that's happened in a material way in 30 years. And at least at a lot of states, that has not had a material impact yet in making it easier. I do think that the leader of Medicaid, Dan Brillman's working really hard on that. But the history here would suggest, loss of care versus gain of jobs.
Yeah. And now, John, this is settled from the big, beautiful bill from a year ago. There is something new besides just the fact that rules are coming out and this is going to go into effect, which is a new rule that narrows the definition of medically frail. So a person, let's say, with cancer, with HIV, has been considered exempt from needing to work, the same way someone who's pregnant or disabled or caring for young children has been exempt. And what this rule is doing is it's saying it's no longer enough to go into the electronic medical record and say the person's being treated for cancer and therefore they have cancer and they're exempt. They now have to document it in some other way, which isn't defined. And the states are arguing this has happened at the last minute when the informal guidance had not suggested that at all.
Yeah, I think that it's important to acknowledge that this is going to affect all of the substantial coverage that was created in the 41 Medicaid expansion states, and that there are exceptions for this 80-hour a month requirement for pregnancy, caregiving for young children, disability, addiction treatment, people meeting the current food stamp or SNAP and TANF requirements. And they had indicated medical frailty. I do think that is to your point, an undefined term. And as they've gotten closer and closer to the end of the year, have come up with this new definition that I think I still think is somewhat imprecise, the way I read it, and certainly is a narrower lane than the initial enabling legislation suggested. But I think this whole thing is going to be complicated to implement, frankly. And I don't know that we've got a path. I mean, there's a lot of focus on this medical frailty piece, but I think a lot of states aren't ready for the January 1 implementation. But let's stay on the medical frailty piece, to it's not a term it's more of a term of art than science. And I think what the federal government realized is that if they really want to push this work requirement piece, they had to be more precise, and I think they just got there later in the year, and I think that's triggered. I think it's how many states are suing them now on this term? Is it about 18?
It's 20. It's 25 states plus the District of Columbia.
Yeah, amazing.
So it's a lot, And John, I think I don't want to say to be fair, because I don't think we ever promised to do that. But in order to give an argument that would be accepted by more people, you could look at it and say, okay, if you just put medical frailty, well, that's just like a big exemption, and you could claim you're frail for whatever reason. I think the challenge is it's not that they've defined it more precisely. They've just said it's not enough to use the documentation that they had previously said was legitimate. And the basis of the lawsuit is that the administration is going beyond what was legislated, and that they're therefore violating certain laws that exist in order to prevent that. So there's the Administrative Procedure Act, and then just the spending clause of the Constitution. So they're saying you're just not allowed to do what they're doing. That's the essence of the lawsuit.
Just to be clear, it was, I believe, initially the informal guidance was if you can show that you're medically frail through a documented medical record, through a credible medical claim, that you could show that you were, too sick to work effectively. And now there is, I think, an external requirement that says it's not enough that historically you can show that I'm going to use a more conventional phrase of too sick to work, that you have to prove your medical frailty. But I'm not sure it's exactly defined.
No, it isn't. It isn't, John. And that's part of the point. So, and this gets back to also what happens. So the states have been trying to, mitigate the effect of this. In other words, they're trying to make it so that people that are legitimately eligible stay insured. And so they've spent a lot of time putting together eligibility systems. They're drafting notices to members. They've been hiring staff. And they, by the way, they face financial penalties if they don't hit the deadline. So they've definitely been on top of it. And they're saying, whoop, there's this rule change now with weeks to spare, and it's not going to work for them. Now, what has worked, in generally where you see these changes, is good sort of customer service, lead time, peer support, clear communications. And states that are trying to do that are finding, they're being cut off.
Again, Medicaid covers the entire U.S. population, so rural, urban, suburban. This is a brand new requirement for Medicaid that is a universal program. There's a lot that needs to change to get this right, and to get it right in a way that can keep eligibles working. Eligibles could find themselves, on Medicaid and working full time and lose their job because they're too busy chasing paperwork quarterly, or they could keep their job and lose their coverage. I think there's always a tension on these new programs where the states say we're not ready because the states are never ready, and the feds put hard deadlines. What makes this more complicated is they, at least in the states' view, change the final rule, within a quarter of the time that the states have to implement it. But David, is there an optimistic side to this? Do you think there's a possibility that this will add to more employment and fewer people on Medicaid, and we'll be in the happy circumstance that what the bulk of America wants, which is that free medical benefits only go to those who are able-bodied and working, or the very sick who are not able-bodied who cannot work?
No, John, I don't think so. And the reason I say that is if you look at, you talked about Arkansas before, if you talk about Georgia, so Georgia, which was not a full Medicaid expansion state, put together a program called Pathways to Coverage. And that's actually what Republicans cited as a model for this federal law. Now, this was a more positive one that said basically, hey, you can get Medicaid if you can show that you're working. And same sort of thing, 80 hours a month, you're at work, school, volunteering, and it was a way to get in. Now, they said that they were going to have, they made a projection of how many people they were going to have, and they only hit 17% of that. So only 4,200 people actually enrolled in the first year, and as of 18 months in, it was only 6,500. And there were probably 240,000 that were potentially eligible.
Yeah, it's a massive number they missed.
Yeah. So people, they showed interest, but then it's sort of like, okay, I have to fill this in. It's like pretty difficult. And there was technical glitches, and the sign up and verification systems weren't that good. So they spent $58 million, which is about $13,000 per enrollee. And it's almost all spent on administration, and it's not spent actually on care. So GAO did a report on this later, and they said the administrative costs were $54 million versus the healthcare costs of $26 million. So if that's kind of continued on. So this was a friendly version. A state was actually trying to get this program to succeed. They only required actually annual re-verification instead of more frequently as you described. And so, yeah, I think it's going to be a challenge. Now, the counterpoint is that in Georgia, okay, a little piece of positivity perhaps. So Georgia says, hey, we didn't say Pathways was to maximize enrollment. And in fact, we think that, the Georgia Access Marketplace plus the Pathways approach covers more people than traditional expansion would have done. I'm not sure if that's true, but that's at least what they would argue.
Well, another possible path is, the Montana is trying to do it carefully. It's already started implementation. They added 60 new staff. There's a 3-month grace period with informational services instead of immediate disenrollment and referrals to job services. So I think some of the states are actually trying to do this in a pretty sensible way to sort of manage this tension. But, I still think there will be, because of how hard it is to set up, because this is an entirely new muscle for the states, and we're changing requirements last minute. It's really hard to believe that, we won't lose a lot of Medicaid eligibles off of the rolls. And the hard part is for folks who are outside of healthcare. Folks who are inside healthcare know what that means. It just means more uncompensated care for hospitals that are already kind of struggling under this administration, particularly rural hospitals. We've had the loss of hundreds and hundreds of rural hospitals. Now the federal government's come in with this rural transformation initiative where they're investing in upgrading the technology. But ultimately, hospitals are really, kept alive because, they have an ability to pay for the care that they're required to give to anyone who walks in the door. And this is going to put a lot more burden on those hospitals, particularly in rural areas.
Well, John, I hesitate to go out on a limb too much on Montana because I'm not familiar with the specifics of the program that they're doing now. But as a rural state, it's one where these providers in the rural areas absolutely rely heavily on Medicaid. So regardless of your political orientation, fewer people coming in the door that have a mechanism for reimbursement means more burden on those healthcare providers.
Oh, there's no question. Because they're already feeling it. There is and the Congressional Budget Office is suggesting, that they're by 2034 will lose about 5.3 million people off of Medicaid, and then with 6-month determination, lose another 750,000, and that will result in a $326 million cut to Medicaid spending over 10 years.
Billion, John. Big B.
Billion,
this is where most of the money is. This is the most of the savings.
$326 billion.
This is most of what justifies the Big Beautiful Bill Act,
tax cuts.
Economics. Yeah.
So they're effectively projecting $300 billion-ish over 10 years in reduction in spend, which is hard to believe from my perspective, because I think of it from a hospital perspective. You're still going to spend the money to justify a lot of the tax cuts that were in that bill, or tax, all kinds of new ways to avoid paying taxes that would otherwise turn into government revenues, funded by this Medicaid, these Medicaid changes. Now, I do think that there probably are smart ways to go at this to get able-bodied people working and leveraging incentives. I just don't know whether running it all through state Medicaid programs, based on the experiences of the affirmative states, Arkansas and Georgia, that were trying to do it right, got it wrong. So I'm pretty skeptical here, even though I understand what the American public at the headline level sort of thinks this is a good idea. At the street level, I think it's going to be a problem.
So, John, let's close out on a couple topics. One is there is this lawsuit that's pending, and let's predict maybe what the court will do and what impact that would have. And then secondarily, I mean, I think we both agree that it's good to have more people working. Let's see if we can come up with some ideas that may not be healthcare related about that. So first, in terms of this court ruling, so if they block the rule before August 31st, is that going to happen, and what impact will that have if so?
I'm the son of a lawyer, not a jurist, but I think that it'll depends on the facts and circumstances and what they bring. Balancing their obligations with the fact that the federal government does pay for 50% of the state programs and really sets the regulations. Just because the regulations are a little crazy in the eyes of or insufficient, it will come down to some process questions about whether they handled the process of change correctly and what the standing and the merits of the arguments the states are making. But I can't really speak to that. I think it's sort of a last minute attempt. And I'm, again, given this administration's success with the courts, I suspect might be delayed, but it's not going to be denied. Just one guy's perspective.
I think that's right, John. And even, let's say, if you take the maximalist view, it's just going to change the medical frailty provisions, and the overall law and the work requirements go into effect January 1.
That's the bigger point. So the bulk of the CBO $300+ billion of Medicaid cuts. Oh, now that's over 10 years. So 30 billion plus per year that were used to fund the tax cuts to our friends and neighbors, but not to take care of the poor. Those largely are going to go into effect, and that is going to shift a cost burden to healthcare for sure. Hospitals, doctors, nurses, vulnerable rural hospitals, and I think that's the part we have to watch carefully.
So, John, let's talk about increasing the labor force participation rate and maybe tie it into healthcare or public health. Do you have any thoughts about how to do it, if not by just making it harder for people to get Medicaid if they don't work?
I think we have to really look at reinvesting in vocational work and practical work, really expanding and investing in the community college system that we have throughout the country that has been underfunded historically, and really focus it towards work. I mean, we've got a wonderful, a small satellite of the UConn Health system. We're in Waterbury, where we have the ability to kind of increase our capacity to educate nurses, and we're actively looking at it. And I think there's an enormous demand for tech talent and care talent and clinical talent. And healthcare is one of the fastest growing categories of employment in America. And we should think about getting more Americans who aspire to care for others. And there really are more Americans who want those jobs than we have slots, and fund the expansion so that we can actually care for the communities that you and I talk about every day and educate them. But I think that's the biggest, if I were to look at an inflection point in terms of getting more people employed, let's get more people trained and leverage the institutions we've got.
Let me add to that, John, by talking about maybe at the other end of maybe the age spectrum or the career spectrum. A lot of people have to retire earlier than they had planned and earlier than they're financially ready for because of their health or the health of somebody they have to take care of doesn't allow that. And so I think some focus on terms of chronic illness, reduction of obesity, or wellness sorts of initiatives that get people moving may enable people to work longer, and that's going to be important for the workforce,
which is also
especially as we have less
great
immigration.
For the health and wellness of America.
Another bonus, John, other than it adds to the Big Beautiful Bill Act's chance of being successful. Well, John, it's I say happy birthday, but I didn't feel like a real happy birthday episode. If I knew we were going to be so negative, I would have baked a cake and eaten it.
We ended up with positives, David.
That's
it wasn't
right.
all
That's
negative.
right. I'll hire you, John, to be co-host of CareTalk anyway. So let's just say that's it for another episode of CareTalk. We've been talking about Medicaid work requirements, attempts by the feds to make them more onerous than what Congress had enacted, and also wonderful things, John, like how well our podcast is doing on Google and how good you're looking for a man of your age.
CareTalk. Well, just recent haircut, Dave.
That looks good. So I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the chair of the UConn Health System. If you like what you heard or you didn't, we'd love more of you to subscribe on your favorite service. And thank you very much for making us #1 on Google.